The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hi, everybody. Thanks for coming back. Thanks for being here to listen to or watch the latest episode, the newest episode of TMD Demystified. I am Tony Urbanek. TMD can be, to some people, to some practitioners, to some dentists, and to pretty much all physicians, mystical. Not necessary. It shouldn't be mystical. It shouldn't be a problem. I could speak a long time on why that is, but I'm not even going to address that today. Today's topic goes to the very heart of why professionals, dentists, and certainly what I term the TMD gurus, those guru meaning doctors who use smoke and mirrors to try to treat the symptoms of TMD. And there are many types of those, but the TMD gurus don't understand the big picture. And so I'm going to try to portray for today what the big picture is. And the topic is malocclusion and TMD. Malocclusion and TMD. So let's define terms. TMD is temporomandibular joint disorder. There is just one disorder when it comes to this problem. No matter what you hear, no matter what you read, it's not a series of disorders. The disorder is inflammation within the temporomandibular joint. That is the disorder. And the proper name, the practical name for what everyone else calls TMJ, just the name of the joint, temporomandibular joint. Everybody has two of those. Not everybody has temporomandibular joint disorder, which is the disease. However, one of the primary issues with TMD, temporomandibular joint disorder, is malocclusion, because it is well accepted by everyone. No one would disagree on this point, that malocclusion, which is defined as problems with the bite, problems with how the teeth fit together, and TMD, in a lot of cases, not all cases, but in many cases, maybe you could even say the majority of cases, go together. And they are related. The question is, and the topic for today is how they're related. And that's what I'm going to try to explain to you easily, and so that a layperson, and we know that a lot of public watch this podcast and listen to this podcast on other platforms, have a very, very strong interest in what I have to say. So I'm going to try to, in the next 20 or 30 minutes, try to make it as simple as I can. To actually have figured this out, it did take me many years and a lot of degrees, dental degree, medical degree in cell biology and anatomy, 2 years as a research fellow with the National Institute of Health, National Institute of Dental and Craniofacial Research, to have the body of knowledge to simplify this problem, which either the doctors don't know what to do, or they misdiagnose it, or they do nonsense and smoke and mirrors. And I've talked to that so many times. It's all on prior episodes of the different varieties of treatment for the symptoms that are maybe partially effective, but only for a short period of time, and definitely don't treat the cause. But we're getting to the point. The point again today is malocclusion and TMD, and what is the relationship? So let's start out this way. Temporomandibular joint disorder is inflammation within the temporomandibular joint, which creates damage. The inflammation can create physical damage within the joint itself. Inflammation creates damage. It's part of inflammation. If inflammation doesn't go on to healing, inflammation being the body's response to damage, inflammation is the body's response to damage in an attempt to heal. That's what inflammation is all about. However, if circumstances are that it doesn't heal, then the inflammation turns into what we call chronic inflammation, which over a period of time can damage adjacent or associated structures, any kind of structure, soft tissue, hard tissue, bone, cartilage, brain. Inflammation causes damage if it doesn't go on to final healing. And so that is the problem with the TMJ. If this joint becomes damaged and it doesn't heal, then you will get chronic inflammation, and then the chronic inflammation can cause bone loss, cartilage deviation, and change in position, which then will lose space within the temporomandibular joint. And when you lose space within a joint, then the bone itself that is associated with that joint can change position. So a damaged joint that loses space within the joint can cause in this case, lower jaw to lose position, change position, which causes the teeth not to fit together evenly. The whole jaw moves. Now, hopefully I'm going to show you something here. Hopefully you can see this. I can show you this, that the jaw moves in unison, and you have the joint itself and the teeth themselves, the teeth and the joint move in unison when people not only chew, but swallow and breathe and talk. So you need this bone, which is called the mandible, to move when you not only chew, but when you talk, when you breathe, and the teeth move at the same time the joint moves. Now, if you lose space in the joint, the whole jaw is going to shift posterior or back, and then the teeth don't necessarily have to move, but all the teeth now don't fit together. So when you have jaw joint problems and you lose space within the joint, patients will frequently complain that my teeth don't meet together evenly anymore. And this can be with or without treatment to the temporomandibular joint. Frankly, it is not uncommon for a patient to come in with all the other symptoms of jaw joint problem, TMD, and they'll have headache, earache, jaw pain, shoulder pain, some ringing in their ears, and they will say, and my teeth don't meet together evenly. Well, what they just told me was that they have already had significant damage within the joint, which caused the joint to collapse, and the whole jaw moved. And now they have their teeth not meeting together evenly. Now, the other side of that coin is that, again, the topic is malocclusion and TMD. So the other side of the coin is that when you have TMD cause malocclusion, you can also have malocclusion cause TMD. Now, The same concept is present, but if the jaw itself, mandible, has a growth problem, if the mandible grows inappropriately, and that's where I have a tremendous amount of experience on facial growth and development and work. And as a maxillofacial surgeon, spent literally 50 years of my career fixing facial and jaw growth problems. We call that orthognathic surgery. Your face is from here to here, and it includes the upper face and the lower face, and primarily the jaws, but also this part around the orbits. And so that is called orthognathic surgery when you have jaw growth problems, facial growth problems of various kinds, which is a whole set of circumstances and a lot of information itself. But when you know how the jaw grows and what areas the jaw and the face grow from, you can actually predict what a face is going to look like and how the jaws are going to function correctly or incorrectly. The point being that jaw growth problems can then end up where your teeth don't meet together. If the jaw grows too far forward or too far back, or it grows so that you end up with an open bite where only the back teeth touch and the front teeth don't touch, that's called an open bite. You can end up with significant forces on the jaw joint that they shouldn't have. So that jaw growth problem, we call that functional malocclusion, can overload a joint, causing damage to the joint, at which point then the joint starts to deteriorate. So it's a two-sided coin. Damage to the temporomandibular joint itself can cause the teeth not to fit together and cause a malocclusion, or jaw and facial growth problems in the space of a normal joint can actually create damage to the joint. And when you have a jaw growth problem causing a malocclusion, now your teeth don't meet together correctly, that can overload the joint and create jaw joint problems. So the three circumstances, we call them circumstances that develop joint damage, are only three. One is constant bruxism over a long period of time. Again, that's chronic overloading the joint, bruxism, too much clenching and grinding. Acute trauma, number two, is acute trauma of the face and the jaw, which can damage the joint. Once damaged, if it doesn't go on to normal healing, then you get chronic inflammation and end up with the symptoms of jaw joint problem, TMD. Or the third cause is functional malocclusion. Functional malocclusion meaning, to repeat myself, facial and jaw growth problems where the teeth don't meet together evenly, whether it's a big jaw, little jaw, setback, open bite, crooked jaw, all those circumstances overload the joint, and you end up over time with the symptoms of temporomandibular joint disorder. Again, single disorder, all associated with the development of inflammation within the temporomandibular joint. Now, that is the circumstance that creates the relationship, good or bad, between the occlusion and temporomandibular joint. Now, the problem that we face in 2025, it actually is December now, 2025, that I'm speaking with you, and obviously you're listening at some other date down the road. The problem is there's a point of view, a thesis out there, basically a theory, that if you just do orthodontics on teeth that don't fit together, then you can solve the problem of TMD by orthodontics alone. And that is a fallacy. That it is a fallacy. And the problem is that we see way too many orthodontists who try to fix and tell patients they can fix their symptoms of jaw joint problems, TMD, headache, earache, jaw pain, neck pain, ringing, fullness, dizziness, by straightening their teeth. Now, let me clarify the difference between straightening teeth. If you have crooked teeth in the jaw, which is certainly a possibility, a lot of people do, straight teeth don't have anything to do with handling or correcting TMD. Now, if you will, straight jaw does, and often you do need the assistance or help of an orthodontist when it comes to fixing a problem when you have a jaw growth problem. In fact, most cases of orthognathic surgery, orthognathic meaning nothing more than straight jaw, but you fix an orthognathic facial case, you need the help of an orthodontist. The problem is a lot of orthodontists who are not enlightened tell patients that if you have crooked teeth, they make your teeth straight, but they ignore the fact, this fact, that the jaw joint itself is already damaged. And the jaw joint is not only damaged, but the jaw itself does not fit correctly to the lower jaw. Mandible does not fit correctly to the upper jaw. And when that is ignored, I don't care how straight your teeth are, you're still going to have the problem. You are still going to have chronic inflammation within the temporomandibular joint. So that is one of the fallacies that is out there, and we see it often. And I just literally 20 minutes ago walked out of a consultation room with a patient who had this exact same thing happening, where the patient was told that doing orthodontics, getting her teeth straight, and she had some problems with straight teeth, but was going to solve the TMJ problem, but it didn't. Why? Because the doctor ignored the position of the jaw and just made straight teeth without considering the position of the jaw. Now, for the dentists out there, the real problem is the difference between centric relation and centric occlusion. I've spoken on this so many times, I'm just repeating myself, but everybody has two bites. We have the bite where the teeth have learned to mesh with or without the help of an orthodontist, and the position of the jaw joint. And those are two positions of the jaw. When the jaw joint fits nicely, snugly, and it's in its comfortable position, we call it rest position within the joint, that's called centric relation. And when the teeth mesh together correctly, that's called centric occlusion. And everybody on the planet has a difference between centric occlusion and centric relation. Because most people have normal facial growth, normal jaw growth problems, 90% do. 10% of the population has a facial growth, jaw growth problem. 10% of the population, but 90% have normal. And when the teeth fit together normally and the face grows together correctly, as it usually does, there is a small difference between the two bites, between centric relation and centric occlusion. And pretty much if there's a small difference between those two different bites where the teeth fit together, when they mesh together, it feels good. When the jaw drops back, teeth don't mesh together, but that is the second bite. That's bite number 2. When there's a small difference between those two bites, pretty much everybody can accommodate that difference. Most people not even aware there is a difference between the two bites, but everybody on the planet has two bites. Everyone, when you push the mandible jaw back just a little bit, their teeth won't hit together correctly, but the jaw joints are in its most comfortable position. But if the difference between the two bites is significant, and the significant change can be as little as a couple millimeters and then go all the way up to an inch. I've seen as much difference in jaw growth as an inch difference between bite 1, where the teeth mesh, and bite 2, where the condyle or ball fits nicely in the socket. And those patients, we call those functional malocclusions. When they get beyond a small difference, we call them functional malocclusions. Big difference between bite 1 and bite 2. Though that is one of the primary causes of temporomandibular joint disorder. Cause meaning causing damage to the joint, inflammation in the joint, and inflammation causes the symptoms. So one of the issues is orthodontists who tell patients that they just need their teeth straightened. That doesn't fix it. Again, there are enlightened orthodontists who understand what I just talked about, and then they can address, and it is possible to address making changes in the bite to get bite 1 and bite 2 as close together as possible. That is possible when the difference between the two is not too great. But if the difference between the two is ignored and not considered when the treatment plan is developed by the orthodontist, it's not going to help TMD. So, and then we have, and we've talked about it so often, then we have the gurus who just treat symptoms with machinery and myofascial, different kinds of mechanical treatment, unmechanical treatment, Botox, and all that stuff that I've covered before, that at very best just treats a symptom for a very short period of time and never even thinks about addressing the actual cause, which is inflammation in the joint. And this whole concept can be proved right here and now. And that is why we know, when I say we, the patients, the dentists, the physicians, the oral and maxillofacial surgeons, that know that if you have been identified as having TMD, inflammation within the joint, non-steroidal anti-inflammatories work really well. They do work really well for 2 or 3 weeks at most, at which point then they run out of steam. But it proves the point. If you address the inflammation, make the inflammation go down, the symptoms will go down. The problem is non-steroidals have a very, very short lifespan on being effective. What does it take to have a longer lifespan? Well, it's not drugs. Non-steroidals work really well, but if you use them too long, then you damage your liver or your kidneys, and you end up on the transplant list. Not a good idea. But the easiest way to do it, the best way to do it, the way that I developed to figure it out, is just to unload the joint with a device that unloads the joint over a period of time, allowing the inflammation to go down. And there's a protocol with it. But again, getting back to malocclusion actually is one of the causes of TMD. And if the damage to the joint is caused by one of the other causes, acute trauma or bruxism, then that can actually cause malocclusion. And you need to know the difference. And frankly, most 50% of the dentists don't want to listen to anything about TMD because they already believe there is no solution. And then 50% of the dentists make a night guard and give it to the patient and tell them this is the solution. Well, a night guard, the only solution a night guard gives, it protects the teeth so you don't crack them. You don't break your teeth. You don't crack your molars when you're bruxing all day and all night. But again, 50% of the dentists make a night guard and tell a patient this is your treatment for TMD, and a night guard doesn't have anything to do about decreasing inflammation within the temporomandibular joint. It just gives you something else to chew on while you're bruxing and overloading the temporomandibular joint, creating these symptoms. And that is the situation we're in. And then we get back to the TMD gurus, and I would include Botox in the list of TMD guru treatments. And Botox has been proven to be no more effective than saline injected into a muscle as far as its effectiveness on making the muscle relax. So malocclusion and TMD is a two-edged sword, has two sides to the coin. The patient and the doctor needs to understand that damage to the joint can cause malocclusion, or malocclusion created by damage to the joint due to trauma or bruxism then is associated with TMD and cause. I think I made my point. I hope I made my point. I really hope I made it simple enough so that patients can understand it. I hope I've made it easy enough for the doctors to understand it, for the dentist to understand it, because I can lecturing to doctors about this throughout the United States. And I lecture both to dentists and physicians, nurse practitioners, and physician's assistants. That's very interesting. Physician's assistants and nurse practitioners know they don't know, and they take up this information very rapidly, very gratefully. Lecturing to physicians and dentists is another story, because most often, especially the dentists, they either know that nothing works and don't want to listen, 50%, or they're in the category that make a night guard and hope the patient doesn't come back. But lecturing throughout the United States on this problem, it is a known issue with getting doctors to kind of look at it from a different point of view than they've been used to looking at it. Getting past that point is sometimes quite difficult. The proverbial status quo, both in the private practice arena and especially in the university dental school arena. I found that out also. Literally, I've been told I don't want to listen. I don't want to listen. And we won't go into that, but I can document that. All right. If anyone would like to comment on my episode, if anyone would like to share some information, if anyone would like to criticize, I am available. I can be reached at tony@tmjservices.net. If you are a doctor, if you are a dentist who would like to learn how to treat TMD successfully, very simply, non-surgically, using a device and protocol, you need a little education. You have to take an online course or a personal course. We offer that also. That information and registration for online or in-person course can be done at www.tmjurbanek, urbanek.com, tmjurbanek, tmj.com. But I'm open for information, criticism. Make sure if you would like to discuss it with me, and especially if you'd like to criticize what I have to share and what I have to teach, make sure that you're prepared to bring your proof, and then we can discuss it in a very academic way. I do want to share, I do have a very interesting episode coming up. I believe it's on it's on the 16th of December, where I have a patient who exhibited exactly what I talked about today, the problem with an orthodontist developing treatment and actually starting too early on the treatment itself with the intention of solving the temporomandibular joint symptoms, and actually ended up creating more symptoms. And that needs to be discussed. And I think it'll be outlined by a very, very nice patient who I'll interview on this episode, on the next episode, which is scheduled to be on the 16th of December. Until then, I look forward to our next episode. I look forward to teaching those who want to listen and learning as much as possible about solving this terrible enigma, conundrum, that everyone in the world calls TMJ, the name of the joint, for the betterment of the patients who have this terrifying, sometimes, problem. I'm Tony Urbanek, and this is TMD Demystified.